Everything said on this podcast is entirely for entertainment purposes only. This is satirical and should not be considered clinical advice. In any situation, please use your own clinical judgment, using your own knowledge, expertise, and research. Consult with your local eye department if you're unsure, and always act in the best interest of the patient. Do not listen to the things that we say and take it seriously.
Hi guys, welcome to another episode of Glasses Half Full. Today hopefully we'll be discussing common and maybe slightly less common clinical conditions and the management, how we explain that to the patient. Hopefully we can all learn a little bit from somebody else and learn something new. So, Mehdi, say you have a patient presenting with a subconjunctival hemorrhage.
Yeah.
And you've done all the tests, you're confident with the diagnosis, not that you've diagnosed it to the patient just yet, but that's what you think it is. How would you explain that?
It's a bit of a random pathology that you've pulled out of the hat. But
completely random, completely unprepared, just out of the blue.
Not read up on this at all, by the way.
Because you need to read up on the subconjunctival hemorrhage.
Yeah.
100%. All the papers on those.
All right, well, the good thing about subconjunctival hemorrhage is that...
You're telling me or the patient?
Sorry?
You're telling me or the patient?
Oh, I'm meant to be telling the patient?
Yeah.
All right. I don't have to tell them.
Okay, tell me then.
So this is Mr. Smith. He's had a subconjunctival hemorrhage. How would you
Have I examined everything?
Everything's examined.
Okay, so I've got some good news for you. That being that the bleed on the front part of the eye is not actually as serious as you think it is. It looks horrendous, obviously, because it's like a big bleed in the eye, but it actually just goes away on its own. It does take a little bit of a while. I'll give it about a week or two for it to wear away, but it will not affect your vision in any way, shape, or form. Okay. We call it a subconjunctival hemorrhage, which is basically the fancy term for a burst blood vessel that's leaking into the layer between the white part of the eye called the sclera and the layer called conjunctiva, which is on top of it.
That's what has conjunctivitis, right?
Yeah, that's where you have conjunctiva. That's where the conjunctiva gets inflamed.
The front part,
which is the front part of the eye. So that bleed's basically kind of lodged in there, and it kind of just flushes out on its own, basically.
Where did it come from?
So the most common cause is like sudden trauma, which like a blow to the head. Some cases with people with blood issues and blood vessel issues, it can be things that are a little bit more sensitive, like sneezing, and relatively older patients as well can cause it. So obviously I don't know what the patient has had recently, but you'd be tailoring it to them.
80-year-old.
So like you'd be tailoring it to them. So like they'd be like, "Oh, I was gardening and like I hit my head somewhere." Like it's probably because of that. But then I would also mention if like they have no history of medicine, like no medication or any history of high blood pressure, I'd be like, if it recurs more regularly, I'd recommend a visit to GP because sometimes that can be related to high blood pressure. So I'd recommend maybe a visit there. And then I'd also mention that if there's any discomfort, just use some drops. Just to make sure
so if I was the patient and I was to ask, will this happen again?
Yeah.
Yes.
I'm not saying
this will happen again.
I would say it's depending on the age, obviously. So like if it's a relatively young patient, I'd be saying it's unlikely, unless it's like relative trauma towards that area. So if it's like a blow to the area that can burst a blood vessel.
So it depends on what caused it.
Yeah, it does depend.
If it's a boxer who got punched in the face,
then you'd probably expect it more.
Exactly.
But if he's like a lawyer or if it's relatively young and like, because you ask about the occupation and what they do and things like that. So like if let's say they say that they're playing football, I'm like, well, it could happen if you're playing football again.
True. How would you answer that if you had a patient with subconjunctival hemorrhage and they were to ask that, will this happen again? Would you add anything or say anything differently?
Yeah, well, I mean, the way I phrase it to patients, it's a bit like a bruise where you have a bit of a burst blood vessel inside the body, and it looks like a bruise. The bruise in the clear part of the eye shows a bit more red, which is why it looks more prominent. I'd say it's about as likely to happen as a bruise. It's not something that I can promise you it's never going to happen again, and it's not something that I'm going to warn you is going to happen every day for the rest of your life. But it's neither here nor there.
I think what Mehdi touched upon with it being, environmentally cause-based, whether it's a blow to the head, like the boxer example, or say, for example, somebody has a recurrent cough. Someone who has a recurrent cough is going to have a bit more than somebody who just, just
Yeah,
fell.
like, you know what? If someone has COPD and high blood pressure,
it's a bit more, exactly. So you tailor it to the patient. And if I, as a patient, was to ask, oh, it happened, it started, or my wife noted it 3 days ago, you're saying it's going to get better, but since then it's gotten worse.
Yeah. So thing is, what I would in that case, I'd say it appears like, depending on how bad it is. So it might have been like a little spot and it's gotten worse. I'd be saying just monitor it. Okay, if the whole eye goes fully red, then come back and we'll have a look, because then it could be.
So you'd review it.
I'd review it if it's like still getting worse.
Yeah, what you say is,
But
if
usually,
you feel like it's getting worse, then
yeah.
come back. But I would rephrase. I think it's important to set the expectations at the timeline. You can't expect a subconjunctival hemorrhage to
get
heal
better
in 2 days, especially from first appearance. You say to them at the time they come in, within about 10 days, 2 weeks is about the time it should take you to clear. If it's been 2 weeks and it's not cleared, or if it's getting worse than that time, then come back.
Yeah, I like that. Oftentimes when I have a patient with subconjunctival hemorrhage, it's a case of the blood's pooled up in an area, and as that blood that's pooled up, as it dissipates and spread out, it can make it look like it's getting a bit worse over a couple of days, and I can still see a bit of that collected blood, only in really not extreme circumstances, but quite advanced subconjunctival hemorrhages. So oftentimes it is something as simple as, yes, this is why it looks like that.
Have you also seen when it's starting to clear around the edges, it's got like a yellowy hue as well sometimes?
Yes, absolutely.
And like they sometimes think they're getting jaundice. I'm like, no, calm down.
Do not worry about that.
Do not worry about that.
Do not worry about that. Fantastic. So, Shoaib, say you have a patient who you believe is at risk of, or at some stage has developed a level of glaucoma. Now, say they do not have any family history of it, so they're not very familiar with it, but say it's clear cut, highly at risk of glaucoma. They're older, they've got the high pressures,
wedge defect, field defect, all that stuff.
OCT, narrow angle, so it'd be closed angle.
Splinter hemorrhage.
That bad, geez. But yeah, closed angle glaucoma.
Closed angle.
Yeah, or open angle.
Yeah, open angle.
Let's do open angle. It's a bit more common if it's open angle.
Yeah, closed angle. I'm more thinking about AD. Yeah, open angle. So I'd start off by setting the scene. You explain some of the basic physiology and the anatomy of what's happening here. I'd show them a diagram of the eye or a model of the eye, and I'd say, this is the nerve at the back, this is the part that connects the eye to the brain. Inside of the eyeballs is jelly. Sometimes the pressure can be a bit too high inside of the eye, and that can push on that nerve and cause some damage to it. And there's some of these signs that we're seeing on the OCT scan and on the pictures of the eye. When I had a look at your eye, the pressure seems a bit high from how we've measured it with the puff of air test, and when I've measured it with the
Would you explain the vitreous humor? Would you just explain that in terms of anatomy, or would you explain that in terms of the pressure?
Oh no, I'm saying there's a jelly in the middle of the
eye.
eye.
Oh, just explaining the anatomy. Lens here, jelly's here.
Yeah, lens here, jelly's there, and the pressure inside of the eye. So it's not the vitreous that's causing it.
Yeah, of course. Exactly.
I don't believe the
vitreous
is causing
it. Aqueous humor.
Somebody with a PVD is like, how has this happened? There's no vitreous contacting the disc.
Yeah, it's just checking if you weren't explaining that. Aqueous humor, not the vitreous.
Aqueous, of course.
Sorry, continue.
Aqueous. So I'd set the scene by saying the pressure can sometimes be a bit high, and that can cause pressure to the nerve, and that can damage the nerve slightly. From what we've seen, the pressure seems a bit high, and the nerve seems to show some early signs of damage. I would always set the scene in terms of glaucoma being a very slow, progressing, gradual onset condition that doesn't cause symptoms until it's manifested for quite some time. So I'd explain to the patient that they've done something very good by coming in early and having these tests done, and we're quite
not that early.
Not that early.
But yeah,
as in relatively to being completely blind. I'd say that we're quite lucky to get in this early, and I'd explain that I'd want them to be referred to the hospital for a second opinion, to be diagnosed with it. I'd say, this is what I think it is. I'm going to get you referred to let a consultant or a doctor give their opinion on it. If it is, then the treatment for it generally is drops, which they use to bring the pressure inside the eye down a bit. You'll be on these drops essentially forever, and the hospital will want to monitor you once a year or so just to keep an eye on things. If they have any follow-on questions from there, I tend to just go on the questions.
They say, but I'm not noticing anything, but what you're saying sounds pretty serious.
It isn't something I'd tend to reassure that it's not anything that. It's not a case that you're going to wake up tomorrow and be completely blind. It's nothing that you need to panic and worry about at this stage, because any steps that could be done to better your situation have been done. You're here. You've had an eye test. I'm referring you. You will be seen at the hospital in due course. This is as much as we can do. What's in our hands.
When they like ask me if they think like it's serious or will I go blind, I'm like, well, if you don't do anything about
that's
it,
a different question. Like, will I go blind? Because that's quite.
But like, even if they ask if it's serious, I'm like, well, if we don't do anything about it, then yeah, you can potentially, if we do nothing, can lose your sight. But you're here. We've detected something. We'll send you to the hospital.
Exactly.
And we'll stop its progression.
We're on the right course of
and
action.
that's what we'll do.
So, and when you explain glaucoma to a patient, have they ever recoiled, or have they ever gone like, so will I have to take this every day for the rest of my life, talking to the drops?
I've had one patient being like that, and I was like, yes, but as a result, you'll be able to keep your vision.
Yeah, you have to be very clear with it. They have to be.
You have to.
But I will also, like, sometimes the hospital may feel like it's better to do like a surgery or a laser surgery. And in that case, then you might not need to. But most glaucoma patients do require drops, but it preserves it preserves your visual field, so you'll be able to see basically.
Would you answer in a similar way if your patient was to ask, "Will I go blind?"
Yeah, what I tend to say is that somebody could have this condition in full-blown effect for many years before they start to lose their vision seriously. So I wouldn't be too concerned about going completely blind. It's a very gradual, slow-moving condition. We're quite early, relatively, in the progression of the disease, where we are intervening now. So if you're using the drops and you get this managed, then we're going to preserve, hopefully, quite a lot of your vision.
One thing that I really try to clarify with the patient is that it's a degenerative condition that we can't regenerate the nerve.
Yeah.
The optic nerve, once it's damaged, we can't bring that back.
Oh yeah.
That's
when I set the scene of like some people who have it for 10 or 15 years, and then it starts to affect the vision, I say at that point it's too late to step in to save that vision, because once it's gone, it's gone. But right now, more or less, it's all there. There's a slight early beginning of maybe a bit of a visual field defect, but by and large, you've still got most of your vision, and we want to keep that. So that's why we're.
And I think that clarification goes a long way. I think that clarification that and you did mention it when you were talking earlier.
Yeah.
But that clarification in terms of showing the seriousness and the importance of taking the drops, going to the hospital.
And it all links back to that initial sort of explanation of there's a high pressure and that's pushing on the nerve. If that nerve gets damaged, that starts to affect your vision, and you can't repair a nerve. It's something that you've got to try and prevent before it happens.
Definitely.
So, Osman, let's say, for example, you've got a patient in front of you who's suffering from a retinal detachment. How would you explain that to them, and how would your explanation differ if it was macula on versus macula off?
So, what's this patient presented with? Just because that's going to affect my explanations. Flashes, floaters,
flashes,
hair,
floaters,
curtain, cloud.
Flashes, floaters, and the curtain in the vision.
All of it.
All of it.
All of it. Okay.
In one eye. Recent answer.
I'd hope so. That's fine. Funnily enough,
I mean, it's not, but okay.
Funny. So this is funny.
It is hilarious. Funnily enough, most of the flashing lights, not most of the retinal detachments I've seen have come absent of flashing lights and floaters.
That's interesting.
It's the vast majority, and I've seen a few, more than I feel I should have.
100% of mine have.
1 out of 1. It's a shadow, it's a cloud, it's a curtain.
Yeah.
It's never a veil.
I've never had flashing lights or floaters.
Have you never?
I've never had it either.
I would briefly explain the anatomy. Normally, the clinic has a nice chart on the wall, etc. That's very much to scale, of course.
Mm-hmm.
And I'd explain that the retina is where the light hits. That's the important stuff. It's where the photoreceptors are. That's lifting off a bit. And if it's torn a little bit, I'd mention that it's torn. And that's less than ideal. And that it's good that they've come as urgently as they have come. If I'm being perfectly honest, I'll say that for most spectrums of how long they've come, whether they've come same day or whether they come a week later, because I want to make sure the patient's at ease. Okay. If it has come a little bit later on, for example, if it is macula off, then we'll see that it's progressed a little bit further than we would have liked to. I'm not going to tell them that you should have come sooner, because that's not really what they need to hear. That's not what they need to hear at this moment in time. And you just mentioned that it's progressed a little bit further than we would have liked to, so the prognosis, while still will be beneficial, there's still a bit of leeway with that. I would explain that this is very much sight-threatening, and I'd encourage them to understand the importance that this is something that unless we treat now, then it's a case of this is something that could result in a complete loss of sight. The causes of it would depend. So say flashing lights and floaters, okay? I would explain that, say for example, if the patient's older, I would explain
like
that
PVD related.
exactly, something like that. The vitreous is pulled on a little bit, and that pulling's tugged the retina a little bit. It's called a bit of a tear. If it's trauma related, bump to the head, knock to the head, that's just lifted off a bit. If it's myopic related, mention that short-sighted eyes tend to be a little bit larger. Larger eyes tend to be a bit more strained. A bit more strain causes a bit more likelihood of tears, etc. That's normally quite easy for them to understand because they think of balloons, etc.
Yeah.
So, and then I would, just get on the phone, explain to them that you can have a seat outside. We're doing everything we can. You know, you've done the right thing in coming in. I'm going to get a quick call on the phone in the hospital and see if they can see you ASAP.
Yeah.
Really.
Or send them straight to, depending on your local referral guidelines and the local.
I usually say I'm going to call the hospital to let them know that you're coming. So just say while I write a referral letter for you as well.
Yeah, depending on where I'm working, it might be a case of, you know, I'm going to call a hospital just to let them know that you're coming, or I'm going to call a hospital if they can make an appointment for you, so on and so forth.
Yeah, it depends. Some hospitals would prefer you send it letter in hand.
Yeah.
Without even bothering to call, they're fine with that. Some would say they just make an appointment. Depends.
Yeah, I've not had nowhere that I've referred has said that next time, you know, just send them a letter, etc. So I'm quite happy to still just.
Oh yeah, it's courtesy, isn't it? To the
Have you ever locumed at let's say a store that's really outside of any local CCG that you've worked with, and how have you dealt with, like, how would you, let's say, deal with a retinal detachment they have there if you don't have like the number of the hospital that you call?
What, somebody doesn't have a hospital?
No, like he doesn't have the number of the hospital to call, but you see a retinal detachment. How would you refer that? Would you just letter in hand?
You search the local.
Yeah, it's. I just asked them to get in contact with the director and ask the director what's the best hospital for retinal detachment, and he just sent me one.
Yeah.
It's happened once in one that's not that far out, but it wasn't somewhere I was very familiar with.
Yeah,
and it was pretty straightforward. And it was a teaching hospital, which was handy. So it would be something like that. There's always someone you can ask, etc. Or you just Google hospitals.
The local LOC guidelines normally have indications of where to send emergency referrals.
But it would be an uncommon case if you're in that situation. It could happen, but if you're in that situation where there's no other resident optometrist, there's no manager, no one to give you a hand.
And call them.
But then most places have a referrals folder, some guidelines, etc. So if there's nothing like that, then sure. I'd Google it and call. Yeah.
Fair enough.
And macula off. I just say that the center of the eyes lifts off a little bit. That's why I presume you can't see quite as well. That's why the vision's dropped, etc. And then the hospital, which is probably have a bit less urgency when they'd see them.
So with that, they would always ask, "Is my vision going to come back?" or "What's my vision going to be like?" How would you tell this to someone with macular off?
Because thinking about it, if it's only just off, you probably could preserve still a lot of vision. Just because the macula's off doesn't mean that the eye's completely gone. At that stage, it could be they're still 630, 660 best corrected, you know, with treatment. But then if you leave it and they say, "Oh, forget it, my eye's gone anyway," they go home counting fingers.
But would macular off be 630? I can't. It's more binary, isn't it? It's more like you can either see or you can't. And it does depend on how off it is.
Exactly.
Yeah, exactly. It's a case of the text would say one thing and practice is a different thing.
Yeah.
It all depends, really. The underlying, and this isn't just the case with retinal detachment, it's the case with every advice and every treatment.
Yeah.
It's a case of whatever the outcome is better with treatment.
Yeah.
Whatever the outcome, I'm sending you because I believe it's going to be better with the treatment.
Yeah.
Okay. So with your sight return, that's why we're treating it. You know.
It's hard to say.
Will it be to the level that it was before? You know, it's hard to say.
It's not really hard to say though.
Like, if it's macular off, you say your vision is going to be somewhat worse.
I would say it's highly, I wouldn't say highly. I say it's unlikely that they can salvage the vision that's already lost.
But the vision's such a spectrum. You can't just say vision. It's like you have movements on one side and then you have six
that's
on the
what
other
I
side.
say. It's unlikely that we'd be able to retain all the vision that you've lost.
Yeah.
But we'll send you to the hospital and they'll do their best to see what they can do.
Because let's say they had
That's what I say.
a superior temporal, where most,
I had one of them recently.
superior temporal is where it's more likely to occur anyway. Superior temporal came down, it's just macular off here.
Yeah.
Immediately up to A&E, lasered.
Yeah.
That entire inferior nasal retina is still attached. They're
Yeah.
still going to get
So
a good field of vision to the periphery. They're driving
the one retinal detachment I had was exactly what you just mentioned, and obviously she was like quite stressed because she lost her vision, and I told her that what it
macular
was.
off.
Yeah, macular off. And she asked me, I was like, look, the good thing is that you still have 3/4 of your vision left.
Exactly.
So we want to salvage that. Anything extra is a bonus. So we'll just send you off, and hopefully they'll do the best that they can do. And I send her off like that.
It's one of those things we have to say. I can't give you any assurances of what it's going to be. I can't tell you what it's going to be. There's no way of me predicting it at this stage. It depends on what.
But I don't want to give them false hope. Do you know what I mean? Because if I say like, oh, it can get better, and then it doesn't, that's kind of like.
No, there's a very clear distinction between we're sending you up because there is a possibility that it can improve, and saying we're sending you up to get it better, so it can get better. You have to be very clear. But I don't feel you're giving any patient any false hope, like giving him the possibility that it could improve.
But the thing is, with the retinal attachment, it is pretty definitive, because when you say it can improve, you're giving them.
For somebody
you don't know what expectation you're giving.
For somebody who's got no light perception, for them to have 660 is magnificent.
Okay, but
I wouldn't use the word salvage. I wouldn't use the word salvage. I'd probably say something along the lines of, we're doing what we can to preserve as much of your vision.
I say retain. I don't say salvage. I say retain.
Okay, retain's a better word.
Retain's a better word.
Retain's a better word than salvage.
What the patient that I'm talking about that I had, they had normal vision, and they came for an eye test with a VMT, and then a week later they got a detachment, and they lost that vision. So when they were asking, I'm like, look, like it's unlikely that we can retain all the vision, but we'll send you off and.
You said an important word there.
All the vision.
Yes.
Yeah, I say all the vision. Yeah.
So that's very, very different to what I'm saying.
Yeah.
Oh yeah.
Earlier, we were discussing, and the way you're making out to be is that you can't tell the patient that they'll have their sight.
No. I mean, the wording that I tend to use, I tend to not give false hope. So saying all the vision is better than saying just vision.
That's what
I mean?
Exactly what my point was. That's exactly what my point was. It is a spectrum. And the same thing what Shrey was saying, light perception at 660.
Yeah.
Okay. You can tell the patient that we are going to try to improve your vision.
Yeah.
That's not, even though it's definitively not going to be 6.6, etc., etc., etc.
Still an improvement.
That's what I'm saying.
Yeah.
So I will happily and consistently tell my patient that, yes, I'm sending you up to try and manage and try and bring back. Yeah, I'll say bring back as much vision as we can. Will it be what it was before? Most likely it won't.
Yeah.
But we're going to try our very, very best.
Yeah.
It's better than what it's going to be if you don't do anything about it.
And that's the second point. Regardless of how much we can bring back, we definitely do not want to lose any more.
Yeah.
So that's why I'm sending.
Fair enough.
I once saw a retinal detachment. It was he had no symptoms whatsoever, and it was a routine check. It was the morning of my visit 3. No, it was John's one in visit 3 in practice.
Yeah.
I had the assessor coming in an hour.
Oh, you told me this.
I was half an hour behind, and I had to step in and do a few pre-tests just to speed it up. There was a family of 4, I believe, 3 kids and dad, and dad, and I'm doing his pre-test first, and I'm looking at the fundus image, and I'm thinking, he's declined OCT. I'm looking at the fundus image like, that's not right. And then I switched it to OCT. I switched it to OCT during the pre-test. Did the OCT. I can see it going macula on.
So it was very central.
It was literally
just
about a whisker away from the macula.
Goodness me.
And then I immediately left it. I gave somebody else who the 3 kids to pre-test. I called up the hospital straight away, and they're like, yep, send him down now.
Okay. Thanks for listening to another episode. Hopefully we'll all learn a little bit. And see you in the next one. Thanks.